Now let's discuss about upper motor versus lower motor. So before discussing the upper motor neuron versus lower motor neuron disorder, we need to understand what is included in upper motor neuron and what is excluded in upper motor or low motor neuron. Now, upper motor neuron, for understanding the upper motor neuron, we again need to go towards the same figure schematic diagram which we use for the corticospinal tract. And here we go. So this is the same as I've explained previously, the pathway of the corticospinal tract. Now, first, I wanna ask you people a question: that anterior horn cells, are they part of upper motor neuron or the low motor neuron? I will explain the whole stuff, but if you people are aware, that's good. If not, that's also good. Not a problem. The center, low motor neuron. Okay. Okay. Yes, Jawad, you are right. They are part of low motor neuron. Okay. Now we need to explain that in detail. Okay, from cerebral cortex rises the corticospinal tract and ends at anterior horn cells, and from there starting the nerve root. Now you need to remember this, and it's very important that every issue, every problem that includes anterior horn cell or any structure below anterior horn cell will be called as lower motor neuron disorder. That's very important. That's very important. So including the lower motor anterior horn cell, anterior horn cells and anything below it will be included in lower motor neuron, and any disorder that lies above the anterior horn cell, anything above anterior horn cell, corticospinal tract, brain stem, brain cortex, subcortical structure, whatsoever, that will be included in upper motor neuron disorder. That's the biggest confusion we people get about anterior horn cells, so you need to remember this. Now, as I've explained previously, that every segment of the spinal cord has its own set of anterior horn cell and own set of the corticospinal tract. Okay. So, for example, if a person has got an injury at, for example, C5, okay, if a person has got an injury at C5, what you people think? Will it be an upper motor neuron disorder or low motor neuron disorder? He's got a cut at like horizontal cut. Yes, it will be low motor neuron disorder. Exactly. Why low motor neuron disorder? Because it is causing damage to the anterior horn cell, and the structure below it will automatically be damaged. Okay, so what will happen to all the segments of the spinal cord lying below the C5, like C6 to S4? What do you people think? What will happen to them? Will they be upper motor neuron or low motor neuron, or they will be normal? Any idea? Low motor neuron, can't say. Okay, now this is a very important concept to understand. C5 has got low motor neuron, but all the structures, all the segments which are lying below the C5 will have an upper motor neuron disorder. Why so? Now listen, C6, C7 and till bottom, they have an injury to their corticospinal tracts. That means they have an injury above their anterior horn cells. Every corticospinal tract before reaching to the lower segment passes through upper segment. For example, corticospinal tract of C3 will first pass through C1 and C2, then it will reach C3. Similarly, the corticospinal tract of C6 will first pass through C5 segment, then it will reach C6. Similarly, the corticospinal tract of C7, C8 until S4 first have to pass through through C5, then they reach the lower segments. Because C5 is injured, that means the corticospinal tract of lower segment cannot reach them. That means, and for them, the injury is above anterior horn cells. And because the corticospinal tracts have got damage. So if for C6 till S4, the injury is above anterior horn cell, that means that this is an upper motor neuron disorder for them. Okay, at C5, because of injury to anterior horn cell, it will be low motor neuron disorder. And for all the levels below, it is injury above anterior horn cells to their corticospinal tract, so they will have upper motor neuron disorder. Have you got my point, or should I explain it again? Sadaf, I actually received 2 smileys. I just want to know that have you people got my point, or should I explain it again? Okay, okay. Thank you, thank you, thank you. That's very appreciative. Okay, now next thing I want to ask that what will happen to all levels above C5? What will happen from C1 to C4? Any idea? You can guess it, no problem. Not here to examine you people. I'm just want your normal. That's great. Okay, so from C1 to C4, everything will be fine. It'll be good because the anterior horn cells are intact, because the corticospinal tracts are intact. They're fine. So from C1 to C4, there'll be no disorder. There'll be no problem. C5 will have low motor neuron, and the levels below will have upper motor neuron disorder. So this is how we differentiate upper versus lower motor neuron disorder when there is any level of injury. Okay, now as we have discussed about upper versus lower motor neuron, now let's talk about sign and symptoms of upper versus lower motor neuron disorder. Very famous topic, and I think we have. So now you people need to tell me the low motor neuron disorder, sorry, sign and symptoms of low motor neuron disorder, and I am going to explain. So what do you think? What are sign and symptoms of low motor neuron disorder? Weakness? Weakness is a very vague term, Sadaf. What will happen to the muscles? Can you? Okay, first tell me what will paralysis, flaccid. Yeah, yeah. Flaccid is more good term you can use. Weakness and paralysis actually they happen in many cases, and they can be due to spasticity, flaccidity, rigidity, anything can occur. Na? Paralysis is a general term. That means the person is unable to perform anything. That can be due to anything. So you need to be specific. So they are flaccid. Okay. Flaccid, another term. Can you tell me what another term? Yeah, great, great, great. Okay. Flaccid, and another term, can you flash for flaccidity or hypotonic? Okay. They'll be reduced in tone. That is why they'll be flaccid. So it'll be hypotonia. Okay. And another sign and symptom. Any other sign and symptom? What will happen to the muscles? Well, this is all about the tone. Their tone will be reduced and they'll be flaccid. What will happen to their trophy? Either they'll be hypertrophied, atrophied. Will there be muscle wasting? What will happen to the muscles, to their body? Atrophy. Great. That's atrophy. Okay. Atrophy. That was an easy option, I guess. But I want to ask another question. Will there be muscle atrophy or muscle wasting? Don't. Negative Babinski sign. Okay. Look, Galaxy, you haven't mentioned your name. Negative Babinski sign is actually nothing. Babinski sign is either present or not present. You don't label it. If there is no Babinski sign, if there is no abnormality, normal reflex, you just don't mention it. So it's not negative. It's either it is there or either it is not. You don't, there's no negative Babinski actually. Either it is positive Babinski or whatsoever. Okay. Okay. What is the difference between atrophy and muscle wasting? There'll be muscle wasting in it. There will not be muscle atrophy. There's a very slight difference between these two terms, but I actually, wanted to explain it. There'll be, sorry, muscle wasting. I've written muscle atrophy again. There'll be muscle wasting in lower motor neuron disorder. Okay. Now, what is the difference between muscle wasting and muscle atrophy? I want to explain that. In muscle wasting, the number of muscle fibers are decreased. But in muscle atrophy, only the size of fibers is decreased. It means the fibers shrink, but the number remains the same. But in muscle wasting, the number of fibers also reduces. Okay, so that is muscle wasting, and that is what happens in lower motor neuron disorder. Okay, any other sign or symptom? Any other? What about the reflexes? Will they be exaggerated, diminished, absent? What will happen to the reflexes? Any idea? If no idea, you can mention no idea. So, right, diminished. Okay. Okay, diminished. So, which reflexes will be diminished? Superficial or deep? Deep tendon reflexes or superficial reflexes? Which reflexes will be diminished? Superficial reflexes or deep reflexes? Which will be diminished? Should be both. Okay. Now, diminished are the deep tendon reflexes. And what about superficial now? What about the superficial reflexes? Will they be diminished or absent or normal? What? Any idea? Any idea? No idea. Okay. The superficial reflexes will be absent. Absent superficial reflexes. Now, do you people know the difference between the superficial and deep reflexes? What actually the difference is? Anybody? The difference between superficial and deep reflexes? Manahil, welcome you to the lecture. You can also tell me, well, you have joined very late, I guess. But any idea difference between the superficial and deep reflexes? If no idea, you can tell me. I'll explain. Please. No idea? So I think I should tell. Superficial or tested skin like sensory. Okay, that's very close, Manahil. You have answered it good. Now superficial reflexes, super are by sensory and Jawad. Okay, great. You people are almost now. Yes, great. Great, Manahil. You have answered good. The muscle, those reflexes which are produced by hammering the muscles, that are deep tendon reflexes, and those reflexes which are only produced by um, irritating the skin by some object, though those are called superficial reflexes. Okay, any other sign or symptom which you people feel are present in the low motor neuron? Any other sign? What about the fasciculations or fibrillations? Do you have any idea what are they? Fasciculations and fibrillations. Hmm. Any idea? Fasciculations and fibrillations. They are like great, twitching. Yeah, twitching. So these muscle twitches are present in the low motor neuron disorder. Do you people know the difference between fasciculations and fibrillations? How they are different from each other? Any difference? Do you know the difference between fasciculations and fibrillations? No. Okay. Fasciculations is the twitching which you can see with your naked eyes. You don't need a microscope or electron microscope or anything. Fibrillations is something that you people can only see with the help of uh, an instrument like by electromyographic studies. So these are very deep and these are very at the micro level, you would say. And fasciculations are, you know, oftentimes we can also see the fasciculations like muscle twitches we have. Okay, so this is about the low motor neuron. Now let's go towards the sign and symptoms of upper motor neuron. Now you people need to help me again. Now what will happen to the muscle here? Hypertrophy, atrophy, or muscle wasting? Hypertonia. Great. Okay, this was about tone. I was asking about muscle, but okay, fine. Great. Hypertonia will be there. Next, what will happen to the muscle? Hmm? Hypertrophy? No, no, no. Hypertrophy. No, there won't be hypertrophy, Jawad. Come on. There'll be muscle atrophy here also. The only difference is that in lower motor neuron, there'll be muscle wasting with muscle atrophy. But in upper motor neuron, there'll only be muscle atrophy. There'll be no muscle wasting. In low motor neuron, both atrophy and wasting will be present. But in upper motor neuron, only muscle atrophy, but there'll be no loss of muscle fibers. That defines the muscle wasting. Okay, so muscle wasting will be as I've told earlier, will be decrease in the number of fibers that will happen in upper lower motor. Here will be muscle atrophy. Exaggerated reflexes. Great. So there'll be exaggerated reflexes. Which one will be exaggerated, superficial or deep? Yes. Sadaf is right this time. Yeah, deep will be exaggerated. Exaggerated, deep. Okay, deep reflexes. And now what will happen to the superficial? What will happen to the superficial? No, they won't. They will be absent again here. Manahil is right this time. They'll be absent again. Absent superficial reflexes. What else? Yeah. Okay, what else? What else do you people expect to happen in upper motor neuron disorder? Yeah, there'll be no fasciculation. Yeah, no fibrillation, no fasciculation. But you people need to tell what is there. There's a lot of stuff will be normal and which won't be there. Rigidity. No, there'll be spasticity. Sadaf, there'll be spasticity. The muscle be spastic. Rigidity, I don't think so. Do you people uh, you said that before? What you said? You rigidity. You said that before. No, there'll be spasticity. There'll be spasticity. because of increase in the tone. You people know the difference between spasticity and rigidity? Yes, Manahil Babinski sign will be present. Then tell me, na. Okay, I'm waiting for the answer. If you know the difference, please tell. If you know the difference, just in one word, you can answer me in one word. I know it's difficult to write. Spelling difference. I didn't ask for such a big difference. Well, that wasn't. I just asked for the smallest scientific differences. Jawad, agonist is spasticity. Oh, no, no. Agonist is spasticity. No, no, it's not like that. Sadaf, actually, you know what? Spasticity and rigid. Jawad, Emanile, anybody else want to answer this question? Or like, I meant in agonist group. No, I have understood your answer. If you agonist group, no, actually, this is not about the muscle involved. Spasticity and rigidity are different from each other in speed. For example, if the patient has spastic muscle, when you will increase the speed of passive or active contraction, the muscle will become more and more tight, more and more hypertonic. You'll need to apply more and more force to contract them. For example, if you are contracting the knee, if you want to flex the knee, you are, for example, if a patient is in prone lying and you want to passively flex his or her knee, if her or his muscles are spastic, if and you will try to contract the knee forcefully and in very very speedily, then as you will increase the speed, muscle will become more and more hypertonic and you will require to apply more and more force to contract, or you may say to flex the knee. But this will not be case in rigidity. In rigidity, no matter how much you contract, or how at which angle you are contracting, at which speed you are contracting, the tone will remain the same in the beginning and at the end. Either there'll be reduced tone or either there'll be increased tone. So same force will be need to you'll need to apply whether you do it in a very fast manner or whether you do it in slow manner. But for spasticity, we need to be careful that we don't go too fast, because it's like the muscle is competing with us, that okay, if you want to come fast, I'll stop you the way you want me to. So that means the muscle is in competition with us. The muscle does not want us to be very, very fast and very, very active while contracting it. So that's the difference between spasticity and rigidity. Okay. So next, anything else? Babinski, yeah, someone mentioned, I guess Manahil mentioned it. Babinski. Babinski. So what is Babinski? Can anybody tell me? Babinski sign. Babinski, do you people know what is Babinski? Are you people there? Feet reflexes. Feet reflexes. Well, that is, this is the similar answer like spelling difference. Feet reflexes. Okay, flexion of toes and scratching the plantar surface. Well, half of your answer is right, Manahil, and you have actually explained the normal reflex, Manahil. It's normal. Babinski is abnormal response. Yeah, so the extension of big toe stimulating. Yes. So this is what happens. What you have told, Manahil, this is normal response. When you scratch the lateral aspect of the foot, okay, yeah, no, that's okay. You don't need to be sorry. It's very interactive, and I'm very happy that you people are actually cooperating. So two upwards. Yeah, now you've got it, Jawad. So if you scratch on the lateral aspect of sole of your foot and go towards the big toe, there'll be extension of the big toe, and there'll be fanning of your toes of your feet. Okay, normally what happens when you do this, there'll be flexion of toes, and that is normal response on scratching the lateral aspect of sole of foot. The normal response is flexion of toes, but Babinski is an abnormal response, and there'll be extension of the big toe and there'll be extension of the toes. So that is positive in upper motor neuron lesion. Okay, what else? Anything else? Any sign? One more sign is seen here. If you people scratch your head, one more sign. Do you people remember? No, in head. Okay, so there'll be clonus. You people know what clonus is? Are you aware of clonus? What is a clonus? Anybody? Clonus is like rigidity. No, clonus is not like rigidity, Jawad. It's involuntary muscle contraction. In clonus, when you flex knee, it's a maneuver. Actually, it's clonus is a maneuver, and clonus does not occur at knee. Clonus and do dorsiflexion. Well, Sadaf, look, knee flexion is not important in producing the clonus. Clonus occurs primarily at the ankle joint. Okay, so what happens in clonus? That in clonus, involuntary. Yes, it's involuntary. It's not under control. You may say it's not under control. It's an abnormal response, and it is involuntary. That's good. But clonus, how you produce the clonus, that when you suddenly, you perform few passive contraction at the ankle joint, dorsiflexion, plantar flexion, dorsiflexion, plantar flexion. Okay, after few contraction, you suddenly stretch the plantar flexors, and that sudden stretch produces this clonus sign that there'll be repeated dorsiflexion, plantar flexion really fast. It's like tremors, right? So that sign is called clonus, and that is seen in upper motor neuron disorder. Can you tell me any other part where this, other than ankle joint, where this sign can be seen, other than ankle joint? That's great. It's also seen at the wrist joint. Yeah. Arm is a general term. It more specifically seen at the wrist joint. So the two joints show this clonus, wrist and the ankle joint. So there you can see the clonus, and it is an abnormal sign. It is not normally present. Okay, because here is another thing which I want to mention. I've also read that somewhere that Babinski sign is also seen in children under 1 year, because the corticospinal tracts has not myelinated. I don't exactly remember the age, it's 1 or 2 years. They also have positive because the corticospinal tracts are not myelinated. So this is a normal thing in children less than 1 year or up to 1 year. So for them, this won't be positive. Other than the children, this will be a positive sign of upper motor neuron lesion. So that was all my today's lecture, for which I have spoken a lot. And I'm very happy to have you people with me. I really enjoyed, and that was a lovely lecture. I would love to have feedback from your people. Any question from your side, you can ask me real frankly. Thank you so much, Jawad. Actually, I was so involved here. Next time I'll keep a glass of water with me. That was a good advice, by the way. You're welcome, Sadaf. You're more than welcome. And okay, Manahil,